So this is then a study that links to previous research. It is a research based on population registers of Sweden, and it is in this case with a focus on mortality, and it is focused on mortality in the early phases of COVID-19 pandemic in Sweden, where we could use Swedish research infrastructure to get insight into mortality patterns. What? We did test this. Okay, so as an introduction, then I just want to highlight that as a demographer, there is quite a lot of different excitements in all three spheres of demography, all three population processes: fertility, migration, and mortality. So it's an exciting time to be a demographer in the Nordics and also elsewhere. In fertility, we have had, just like in the UK, an fertility decline during the last decade, which is an unexplained fertility decline and where we still cannot rely on conventional data to explain it. And it's very exciting for research purposes. In migration, we had the migration boom, the refugee crisis, so-called, in 2015, and all the consequences and the life trajectory careers of the new migrants to Sweden that we can also follow in registers. And now with mortality, we had the new pandemic in 2020, which has changed the life courses of individuals and also opened up avenues for more research. So we have here the three population processes again: migration, fertility, and mortality. And in normal times, I usually think that the most of excitement that you find in the intersection of the different demographic processes, for example, migration and fertility and so on, which I have done research. And this also holds for the current situation. So as you will see later on, some of the surprising findings that are not yet explained in terms of COVID-19 mortality relates to migration, where we have excess mortality among migrants, the foreign-born people in Sweden, which can not really be explained by the data we have at hand. So there we have one intersection that's exciting. And for the future development of fertility trends, it's also interesting then how the new intervention of the COVID-19 situation, not in terms of mortality as such, but the close down and the effects on labor markets and society, how that may interact with future fertility trends. So it is bringing together the different demographic aspects. Just as a background, for the corona pandemic in Sweden, we had relatively high death rates in the spring in 2020, just like you had in the UK and similar to other Western and Southern European countries, but different from the other Nordic neighbors, which had much lower mortality levels than in Sweden. And we also had a different approach to the pandemic. So in contrast to other countries, we did not have strict lockdowns of societies, but more soft recommendations from our public health authority, how to make physical and social distancing and so on. And currently, like many other places in Europe, we are now in the phase of a second wave of this pandemic. And then of course this open up for opportunities for research, for new mortality research, which we have taken advantage of, thanks to the all-encompassing population register system of Sweden, and also the possibility to relatively quick update of what is happening in the population register data. So we have individual level data, we have longitudinal data for a total population where we can follow over time, and we can apply standard demographic methods to study death rates. And we rely on registers from two key actors. So the National Board of Health and Welfare is the agency who is in charge of health registers and the cause of death register. So we got the data from them, and otherwise Statistics Sweden is the agency that is maintaining the basic population register system and the general administrative register systems of Sweden. And during the spring, in March and April, we found ourselves in different voluntary lockdowns. So we have an international work group here at SUDA, and then people reacted a little bit like the situation in their home countries. So the Swedish demographers came to work a little bit almost as usual, but with a little bit more careful touch, while the European foreign colleagues, they locked themselves in and stayed a little bit more away from public. And during this time, I and a few other colleagues, we got a request from a region in southern Sweden, region Halland, where, where the key actors, both at the government, central government representative and the local region representative, had a background in human geography and demography, and they wanted us to start do some quick research on the key risk factors so that they knew what they could make for counter measures when the pandemic may reach Halland. At this time, it was mainly in Stockholm, and they had not been affected yet, and they wanted us to do a quick study on the risk factors, and so that they could design some local policies. And then we started, after one day of hesitation, we quick started this process, and it was really very efficient work with the Swedish agency. So we had a fast track with the ethical review authority in order to order the data. We had another fast track with the Board of Health and Welfare to get the cause of death register. And normally this register is only updated once per year, but then they provided up to the date until the very last day of data. And we also got the fast track with Statistics Sweden to derive the base population for the study and update the background data. And it was quite impressive. So normally you don't see government agencies working like crazy scientists in the middle of the night, but here we could really communicate like Thursday night at 11 o'clock. Then you get the email from the National Board of Health and Welfare. Sunday afternoon, then we got data from Statistics Sweden and so on. So they were really also on top of things, just like we were at the university when we got the data. And then we put together this group of researchers. So this was in May, and then we collected a team of researchers. And this group actually met on a daily basis, just like we're doing now on Zoom. So they had, or we had, or they had different constellations, daily Zoom meetings the entire summer to design a set of studies where we cover different aspects of the corona mortality situation and different focus and different variables. And so far this has resulted in 5 different studies. So as Hill said, 2 of them are published, one in Nature Communications and one in Lancet Healthy Longevity. And then we have 3 more that are in the review process, and 2 of them are in the very last stages of review processes, so they will probably appear soon. And then these different studies cover different key aspects of corona mortality. Our data, so we started with a collection of registered data that we already had at hand. So that gave us an advantage. We have a project on aging research, where we also focus on mortality and life situation among the elderly. And in this project, we already had cause of death data. So it was natural then for the review authorities to think that we should update our cause of death register with new data for the last period. And then, then as usual, we have individual level information for a rich set of social demographic characteristics. So Statistics Sweden then they collect data from different registers, from educational registers, on taxation registers, and so on, and you can join the different information so that you have a good picture of background information, both with socio-economic and also in the demographic life histories, domestic migration, international migration, civil status histories, and so on. And then we ordered new data, so we got deaths from the all-cause, we added all-cause mortality for two more years, and then for 2020, from the 1st of January to the 7th of May, which was the last date, and which when we got the data, then we got cause of deaths, deaths by cause, and then they were divided by COVID-19 related causes of death, or any other causes, so that we could study then censor if you die by another cause, and we could also study mortality patterns by COVID-19 and compare it to mortality patterns by any other causes during this period. And so our data until May 7 cover the peak of the mortality and the deaths during the spring peak. So it cover the peak, yeah, as I said, and we then have all the deaths during that period, which are reported quite accurately, and more than half of COVID-19 deaths during the first wave of the pandemic. And here is then a diagram which shows that the mortality by days since the first day of the pandemic, where you have the increase, and then you had quite some time, more than a month of high mortality, and then it starts to decline at the end of our observation period. The few last days doesn't reflect real number, because then there is always a little bit lagging behind before the deaths are coming in. But as you can see, we still have passed the peak of mortality during that period, and then this goes on and it slowly decelerates afterwards during this early summer months. And here is then a little bit of the distribution. So as we know, the mortality of COVID is heavily dominated by mortality among the very elderly. So from age 70 and above, we find almost all deaths. And here you have it distribution by women and men. And you can also, if you're a demographer, you can also see that this distribution resembles a little bit like the distribution of deaths also by other causes of death during normal times. Then we apply methods. We are demographers, and then our method to study relative risks of dying, mortality rates, is by applying a Cox proportional hazard or some other life event history model, where we have age as the baseline, and then we have different socio-demographic characteristics as covariate. And this was then important because this allows us to bring out the independent roles of different factors. So at this time, there had been a little bit of general aggregate statistics, descriptives of who are more prone to die of COVID-19, but many of the variables are, of course, related to each other. So it was important that to bring out what is the independent role of different factors, and that would be our contribution. And then our first study was to do a general overview where we looked on socio-demographic risk factors of the COVID-19 mortality. And this Sven Drefall is the first author. And then we have this team of researchers, and this is the one that is published in Nature Communications. So the results, I will present them now, but some of the results were not super surprising. They reflected a little bit what had been presented in aggregate statistics, but then they confirmed what is the independent role of the different factors when you control for the impact of other factors in the setup. So, okay, so the initial statistics then suggest that men, the elderly, ethnic minorities, and people with lower socioeconomic status are more prone to develop severe COVID-19 and dying. And then our task was to see whether this holds also for an multivariate setup with individual level data based on the total population. So there is no selection of who entered the study population. Everybody with a registered residence in Sweden are covered, and then we can follow them during this period of time. Here we have a little bit exclusion. We had that you had to live in Sweden for at least 2 years. This was based on a little bit of the background variables, which are not updated on a daily basis. So then we required that you had to live in Sweden for 2 years to be included. And then, because then we have all the background information from all the administrative registers that are not updated on a daily basis. And then otherwise, we have all individuals age 20 and above on March 12, which is the date for the first recorded death of corona in Sweden. So almost 8 million people, and then we follow them for almost 2 months. And we have all deaths from COVID-19, 3,000 deaths at that time, and any other causes. And then during this period, there was also 14,000 deaths from other causes, more normal causes of death during March 13 to May 7. And here is then the description of the basic results. Yeah, so we did stratified models for the somewhat younger, somewhat older, for women and for men, and this shows the results for men and how we presented the different factors. We have odds ratios, and then we check what is the role of civil status, education, income, birth country, and region. And then we estimated the model for red dots, it's corona-related mortality, COVID-19, and blue dots for other causes of death. And we can see for the first 3 variables, civil status, education, and income, then the patterns are exactly the same for COVID-19 mortality and any other general mortality. So marital status, the non-married, never married, separated, widowed, have much higher mortality. There's an educational gradient and there is an income gradient in mortality, where you have a higher mortality among the less advantaged people. But if we go below this blue line, you can see that patterns are totally different when we look at country of birth and when we look on region in Sweden. So if we first look on region in Sweden, then there is not much difference in the general mortality between Stockholm and rest of Sweden. But during this period, then Stockholm was the center of the pandemic, and much higher, 4 times as high mortality from corona if you lived in Stockholm than the rest of the Sweden. And for migrants, we have this very intriguing pattern that for general mortality, we have lower mortality for people from different countries. And this abbreviation stands for high-income countries, low middle-income countries from in general, and low middle-income countries from Middle East and North Africa. And then we have, for general mortality, we have the healthy migrant effect, where mortality is lower than expected when you control for socioeconomic and family situation, but much higher mortality for corona-related mortality, COVID-19 mortality. So, okay, so this is also the general conclusion from this paper. Yeah. So, being male, having less income, lower education, not being married, and being an immigrant from lower middle income countries all independently predict a higher risk of death from COVID-19. And in our follow-up studies, we could also see that the role of socioeconomic characteristics is much more pronounced at working ages, whereas it is the marital status and the family situation that is that matter most at the advanced stages for the elderly. And then, so sure, then the interaction of the virus and the social environment exerts an unequal burden, where the most disadvantaged members of society are at higher risk of dying even more than in a normal situation. And also these 2 different patterns of covariates. So the socio-demographic correlates are very similar for COVID-19 and general mortality. So this suggests that general frailty matters how you can cope with the corona and how you can cope with survival in general. So there you have the same pattern. But then if we look on the pattern for immigrants and people living in Stockholm, then there are different patterns. And then some of you are geographers, so for you this could be an interesting finding that role of factors related to spatial connections might come out in the corona mortality situation. So, and then we have one ongoing study where we follow up on this. So this is the big unexplained finding, and this is still the conundrum. So why is mortality so much higher among the foreign-born in Sweden? And then we do a study where we focus on Stockholm and we focus on foreign-born, and we do it with more detailed country groupings, and we also add more factors. We bring the factors that have been raised in media, maybe the crowded housing situation, maybe different work characteristics have an impact and can explain this. And then we look a little bit closer into that. And here first, a little descriptive, just that you can see the fraction of deaths of foreign-born and Swedish-born people, where there are quite many deaths among the foreign-born. There are also many foreign-born people in Sweden, but you can see at the higher ages where there are less foreign-born people, you have a substantive proportion of foreign-born. And at the younger ages where there are not so many deaths, there you have a very high fraction of mortality that is contributed by the foreign-born. And here is then a setup where we show COVID-19 mortality and mortality from other causes of death in two panels here. So in the panel A here we have COVID-19 mortality, and panel B we have general mortality. And if we start with panel B, there we can see very clear effect of the healthy migrant effect. And here we have done much more detailed countries of origin specifications. And DACH is for Deutschland, Austria, and Schweiz, if anyone wonders. But then these are the biggest immigrant groups in Sweden. And here you have a healthy migrant effect, generally lower mortality. And the gray curves is the univariate models where you only control for age, the age composition of the migrants, which is the basic demographic parameter. And then the white bulbs, circles, are when you control for socioeconomic factors, household factors, and the population density in the area where you live, factors that have been raised that we thought were important. And when you control for this, then the healthy migrant effect becomes even stronger. So when you control for the fact that many migrants have a little bit less advantageous socioeconomic setup, then the healthy migrant effect is even stronger. So, but then we turn to our main focus, which is COVID-19 mortality. And then you can see that it is much, much higher among almost all immigrant groups. There are a few exceptions. So, but immigrants from Finland, and then particularly from the Middle East and from Africa, have much, much higher mortality. And when we control for the socioeconomic composition, the household factors, and the population density area, then almost half of the excess mortality can be explained, but there is still a very high excess mortality that cannot be explained by the data that we have at hand. And then I will just mention, then so that is still, so even if we look closer at the excess mortality among immigrants, there is still then a big unexplained excess mortality. And then we have one follow-up study by Siddhartha Aradia, where he thought that we should maybe look on couples where one partner is immigrant and the other one is Swedish-born. And the reason why we did this is that in the general debate or discussion in Sweden was the story that since the Swedish corona strategy relies on advice, soft advice from authorities, and then the Swedes know how to pick up this advice and then they behave accordingly. But maybe that was the story in the media. Maybe the immigrants need to have much tougher measures like you had in the UK to understand that it's serious, and maybe they don't understand. So maybe it's something with acculturation. So I never believed in this study, but with this design, then we can test this, whether this makes sense, because you have a couple where one is foreign born and one is Swedish born, then you cannot claim that there is some lack of acculturation, there's some lack of understanding of advice. And you could also have a little bit testing about the role of genetic differences, biological differences that also been brought forward in the discussion. So then if you find the differences within these couples, that could make sense. But interesting with this study is that we find the same excess mortality for both partners in these couples. So the Swedish-born spouse or partner and the foreign-born spouse have the same excess mortality risk of COVID-19. So that is really a strong argument that the acculturation and also perhaps not the genetic differences cannot be important, and they do not contribute to creating these mortality differentials. But the mystery is still there. The finding is not yet explained. So then I want to report a little bit where we follow up on another thread in our study design. And this was headed by Maria Brandén, who is at the Institute for Analytical Sociology, and that's why we have another little logo there with Linköping University, who is a host of the Institute of Analytical Sociology. And she has actually been appointed the newly director of this institute. So she has done a very successful career, and she is also coming from our unit here, the demography unit in Stockholm. But then she focused on the elderly, because that's where the mortality is. And then the focus is on what can explain the excess mortality of different groups among the elderly. What factors may be important if you want to implement a policy advice on how to protect the elderly. And much of the discussion, of course, both in Sweden and elsewhere, has been on how to protect the elderly from the hazards of COVID-19. And then the focus of this study is on living arrangements. So then we looked on whether you live in a care home, whether you lived in crowded housing, and also whether you lived in age mixed households. So if you're an elderly person, you're retired, but there are younger people in your household. And this, of course, is one of the variables that may explain this excess mortality among immigrants. At least that has been put forward as argument. But as we saw, it couldn't explain the general excess mortality. And then she also, or this team also, where we looked also on neighborhood characteristics. So population density, if you live in a very crowded area, or if you live in a sparsely populated area. And we have a lot of space in Sweden, so there are a lot of sparsely populated areas. And the corona was mostly in Stockholm, the capital. So, and again, limitation of past research, aggregate data, maybe hospital data, but you have not adjusted for individual level risk factors. So we want to see how these factors, who are also related to each other, how they hold independently of each other in a multivariate setup. So, and then our variables is then square meters per individual in the household. So everybody in Sweden are registered in an apartment. There is an apartment number, a dwelling unit, and then there is also then information on how big is this apartment. And then we also know the household composition, so we know who are registered to live in the apartment. So you can see if you live alone, if you live with only another individual that is very old, if you live with someone who is younger or a child, and also the type of housing, if you live single family, multifamily, or a care home. And then for neighborhood characteristics, then we looked at the small area, population density, so how many individuals per square meter, but then we also had data on caseload, the number of reported infections in the borough of Stockholm. And of course that is expected to have an impact, but we wanted to see how much and whether the other factors hold when we control for this. And then of course we have standard controls, age, sex, country of birth, income, education. And here are then the results in a diagram of this type of analysis. So here we have, again, we do blue circles. This is the corona mortality setup, and red circles are any other causes of death, general mortality. And then we can see that the crowded housing, the square meter per person, it has an effect. So those who live very crowded, they have higher mortality, but it is not a corona effect. It's just a general effect. Those who live in crowded housing in general have higher mortality. And whether this is due then to more poor living conditions is a likely explanation. But there is not a specific pandemic effect on the crowded housing in the apartment. Then we have the age structure of the household, which is an important variable. And then we have one finding that is interesting and stands out. Yeah. So if you are elderly, if you are 66 or above, but you have someone in the household who is younger and who might be in working age, then there is a higher mortality of corona, but not general mortality. So that suggests that the individuals who have younger people, then they are also more exposed to the risk of getting corona, COVID-19, and dying from it. And apart from this, then we have this very high death rates among the care homes. So this is, of course, a finding that was highlighted a lot in media. And you have a very high excess mortality of COVID-19 if you live in a care home. But you also have a very high excess mortality in general, the red dot there. And then with the local contextual factors, then we can see that if we start with the lower one, population density in the neighborhood, it doesn't seem to be such a huge difference. There's no effect on general mortality. There might be a little bit positive effect on corona-related mortality, but the confidence interval are large. The intervals are large, and the effect is not very strong. But of course, then, as expected, you have a much higher mortality if there is a lot of cases, reported cases in the local part of Stockholm region where you live, or the municipality. Okay, then summary, crowded housing, no additional COVID-19 effect. Age structure in the household, so yes, it might be dangerous to have a younger household member that brings the virus home. But we could also see that the older adults who only lived with another old individual, they had a very low risk of COVID-19. So it seems that the elderly couples, they are able to self-isolate and live a relatively risk-free life. And elderly care stands out, partly due to frail individuals in care homes. And then we could also see that there were no difference between single and multi-family housing. So that means that, as has been suggested, that the elevators, corridors, and common spaces in multi-family housing, that they should be dangerous arenas of spreading of the virus, may not be the case. So there was no effect of living in a multi-family housing. And then, of course, this can be translated into clear policy advice. So it really, if you want to protect the elderly, you have to protect them from working age individuals who work in care homes, bringing in the virus, also from other household members who are more mobile in the city. And also, of course, if you live in a very densely populated area. So I had, there was quite many studies and quite many results, but I only have one small little study. I will do a little resume of that one also. And so sorry for talking so fast, but I knew I only had 40 minutes here, so I shouldn't spend too much time. But this is also an important study. And here we had a look not on the household composition, but work characteristics, so death in the front line. So maybe those people are more exposed to other people who are working in the healthcare sector, who are taxi drivers, ambulance drivers or whatever, they are more exposed to the spread, and we wanted to see what is the mortality risk related to what kind of occupation you're having. And then we do two study population. First, we have 4 million people in working ages, and we look on their occupation, and then we see what is the risk of mortality. So, but we already know that the mortality is it is fairly low in those ages, so we don't expect to find a very strong pattern. But then we also look then on the elderly people, 67 years and older, but who live in a household where another person, younger person, is registered with an occupation, and we can see whether this occupation may have a spillover effect on the elderly. And we look on the COVID-19 related causes of death. And here we have from Swedish registers, we have information, so everybody are registered with an employer and also with an occupation, so that we can pull out. But then we used the data that came from an American government department where had tried to create an index, so to how confronted are different occupations to contact with others and exposure to disease and infection. So that is a survey. And then, that is data on these three different dimensions: contact with others, physical proximity to others, and exposure to disease and infection. And then we use this kind of exposure data, and we link it to the different occupations in Sweden. And then every occupation has a value on the scale from 0 to 100. And we run the study, we run it on working age population, and there we find no effect, or rather a negative effect of high exposure. So those occupations who have a very high exposure to the disease have actually the lowest mortality rate. So that suggests that people, for example, in the healthcare sector, they are also more able to protect themselves from the virus and from the disease and to getting cured. And then here I just showed the diagram then from the smaller population of the elderly who have a working individual in the household. And this is the exposure from 40 to 100. And again, there is no effect of being exposed to other people on the spread of the virus and causing mortality on elderly household members. And we also did this stratified by manual and skilled professions, whether there was some difference there, and there again there's no impact of this. So, and this study quite optimistic. So frontline workers seems to be able to protect themselves from mortality, and there's very little that they are more likely to die from COVID-19. So this was then a little bit happy ending of this set of studies. And this, I'm done now, but then after the happy ending, I will just do a little thing on the study limitations. So of course, this is a very rich data, and we are super happy that we were able to work during the entire summer and create all these studies that we have been excited about. And we had really good collaboration in the group of researchers. It was a relatively big group, quite intense, but there are absolutely no conflicts and really nice collaboration in the team. So, but then on the negative side, what are the limitations? And of course, the limitations are, one, that we don't have health data. We are demographers, so we don't use health data, and we don't have data on diagnosis from the healthcare system and so on. So that we leave to other colleagues who work at the Karolinska Institute to perhaps look deeper into, and they have those competences. But otherwise, the main problem or the limitation is those who are living in elderly care. So that is the group with the highest mortality, but there is some under-registration of moves into a care home. So it's not that everybody immediately register their move to a care home, and they might be registered at their old residence instead. So those who are in the care home, they are registered there. Who are registered in the care home, they are there, so that we know. But then there are also more people who are actually de facto in care homes, but may not have been registered. And I know this because I have, even myself, I have an aunt who was taken to a care home during this period. And of course, she has not registered her move into the care home because of many different reasons. Okay, and then the other limitation that are at the second end of this slide is that maybe the COVID-19 mortality then also have additional effects on general cause mortality, collateral death, if people are not doing care seeking. But that we have taken care of by doing sensitivity checks where we repeat our analysis for the same period in 2019, so that we can then validate our studies how it looks under a normal situation. And sorry for speaking fast, but then there are many results, but these are all in print. So if you want to look closer into this, there are in our Stockholm research reports in Demography Working Paper series, these studies are all listed, and then with links either to the working paper if it's still under review as a preprint, or otherwise to the general publication if it's online.